Good evening. Can you hear me?
Good evening, sir. We can.
The voice is clear.
Yes, sir.
Yes, sir.
Okay. So today my plan is to deal with bone and joint tuberculosis. You remember we have dealt with basically spine tuberculosis in the last class, right? So today I will deal with only tuberculosis of other joints, right? So we'll follow the usual pattern of solving some MCQs and then going to the relevant theory. Okay, right. Okay, anybody just try and answer just to keep the interaction live. Apparent lengthening of lower limb happens in which stage of tuberculosis? Stage 1, 2, 3 and 4. I will come to the stages in a while. Okay, if anybody can just take a chance and guess, or rather I would not use the word guess. So try and answer this question. Apparent lengthening of lower limb in which stage of tuberculosis? Can anybody?
First stage.
Yes, very good, Manjunath. Stage 1. Okay. Okay. This is one tuberculosis. I will briefly explain here. Tuberculosis of hip. There are different clinical stages. Please remember, clinical stages is different, and then comes radiological classification. Okay, radiological classification, if you can remember, it is by name Shanmuga Sundaram classification. Please remember, this is very, very important as far as MCQ is concerned. So that is radiological classification of tuberculosis of the hip. Now coming to clinical stages only. I will explain you clinical stages in a while. So clinical stages of tuberculosis of hip. Stage 1, stage of synovitis. Okay. Stage 2, stage of early arthritis. Early arthritis. Stage 3, stage of advanced arthritis. Stage 4, stage of subluxation or dislocation. And fifth stage is stage of sequelae. Sequelae of the disease itself or sequelae of the treatment. Okay, please remember this. This is very, very simple. This common thing to any other joint also it applies. Stage of synovitis, arthritis and sequelae. But in tuberculosis of hip, you please remember these are the stages. One more important thing is stage of synovitis. These are 5 stages. These are 5 stages you have to remember. So one thing what is important is what is the clinical picture in different stages. Okay, with respect to attitude of the limb and with respect to shortening. This is very, very important. Okay, in stage of synovitis, what happens is there is synovial effusion. So in synovial effusion, what happens? There is a accumulation of synovial fluid in the joint. So the joint is kept in position of maximum capacity. So the joint is swollen because of the effusion. So what is the attitude of the limb? So the attitude of the limb is flexion, abduction, external rotation. Faber, very easy to remember. Stage 1, it is Faber, flexion, abduction, external rotation. Why it is in this stage? Why it is in this attitude is the effusion, whenever it is maximum, the joint capsule has to be swollen in a circular or a spherical form. So in that case, in flexion, abduction, external rotation, the capacity of the capsule of the hip joint is maximum. So please remember, stage 1 is flexion, abduction, external rotation. Okay. So this is the attitude. Faber. Very easy to remember. Flexion, abduction, external rotation. So what happens in stage 2? Before that, so you look at this diagram very carefully. Okay, this is the joint what I was explaining. It becomes swollen entirely and the limb becomes abducted. The limb is abducted, externally rotated. So, and because the limb is abducted, it appears long. Apparent lengthening will be there. Apparent lengthening will be there. Okay, there is no true, in always limb length discrepancy, you remember there can be apparent limb length discrepancy or true limb length discrepancy. So in stage of synovitis, it is only effusion which is collected in the joint and no destruction. The limb is kept in Faber, flexion, abduction, external rotation, apparent lengthening. Because of the abduction, the limb appears long. Okay. Right. This is, I was talking of Faber. So in stage of early arthritis, what happens? You have to remember early arthritis. Okay. Okay. Stage of early arthritis. Stage of early arthritis and advanced. And one more important thing you remember in stage of synovitis, the movements are restricted only in terminal 25%. So there is terminal restriction of movements only. Terminal 25 degrees, 25% of movement. Say suppose the movement of flexion of the hip on an average 140 degrees, only 25% terminally it is painful and restricted. So it is important you remember stage of synovitis, the attitude is Faber, apparent lengthening will be there and the movement restriction is only less than 25%. So what happens in stage of early arthritis? Movement restriction becomes more and more. So up to 50% movements are restricted. And what happens to attitude? Attitude of the limb is Fadir, F-A-D-I-R. Flexion, adduction, internal rotation. Okay, for that I have a diagram here to represent flexion. The limb here has gone in adduction. There it was in abduction. So in stage of early arthritis, the attitude of the limb is Fadir. F B comes before, D comes later. So you remember easily synovitis, it is Faber. Early arthritis, it is Fadir. Late arthritis is also Fadir. So even this is a kind of a mnemonic for you to remember. Flexion, adduction, internal rotation. So how do you differentiate between early arthritis and advanced arthritis? Is early arthritis only 50% movements are remaining or 50% is restricted. So in advanced arthritis, restriction is more than 75% of the movements. And early arthritis, shortening is less than 1 centimeter. So how do you differentiate? Early arthritis also there is a flexion, adduction, internal rotation. late arthritis or advanced arthritis also there is failure, flexion, adduction, internal rotation. How do you differentiate? Early arthritis movements are 50% restricted and shortening is less than 1%. Advanced arthritis movements are more than 75% restricted and shortening is more than 1 centimeter. Of course, stage of subluxation and dislocation, the attitude can be anything depending upon the direction of the dislocation. Okay, so one thing I want to tell you again here is flexion, abduction, external rotation. You wherever I mean you are sitting, just position yourself, your limb like that, and you will know flexion, abduction, external rotation. This can be seen in anterior dislocation of the hip. Please remember, it can be seen in anterior dislocation of the hip. This is an extra point, of course, not connected to tuberculosis I am talking, but you have to remember flexion, abduction, external rotation with apparent lengthening can happen in anterior dislocation. I mean, it can be anterior traumatic dislocation also, right? And it can happen in poliomyelitis. Okay. Similarly, flexion, adduction, internal rotation, failure, move your limb yourself and keep that limb in this direction. You will know this can happen in early and late arthritis of tuberculosis, also in posterior dislocation of the hip. This is an additional point for you to remember with, they call learning with association. Okay. We'll go to the next. See, this is what I was explaining. Synovitis, early arthritis, advanced arthritis. And of course with the stage of subluxation and complication. This is already I have explained. Of course, radiological feature I will explain with the radiographs. Yeah, see, why the limb goes in flexion, abduction, that is Faber, is maximum joint capacity. I told you whenever you inflate a balloon in the beginning, it will be ellipsoid. Then when you inflate completely, it becomes a spherical. Sphere is a maximum capacity volume. That's why when the joint capsule is swollen completely, it goes into flexion, abduction, external rotation. Right? Okay, these are other things which I don't want to go. Okay, wandering acetabulum. Can anybody try and answer this? Wandering acetabulum is seen in. I would be happy if somebody can try answering this. Right or wrong, nothing to be disappointed or disheartening. It is only
Fourth
that.
option, sir.
Yes?
Fourth option.
Very good. Just because that we are dealing with tuberculosis?
Yes, sir.
Okay, right. I will show you a picture of wandering acetabulum so that you will never forget. The answer is right. Okay, this slide is little busy. I will come to this later. Yes, Shanmuga Sundaram classification, what I was mentioning, you should know this. I have told you radiological classification of tuberculosis of the hip. Okay, see, please remember. Okay, my pen keeps disappearing. Okay, see, type 1, it can be normal. By this, what we mean is X-ray of the hip, pelvis with both hips can be normal, even if the patient is having tuberculosis. That is also one type. Then comes your traveling acetabulum or wandering acetabulum. Okay, I will explain you that in a minute, but please remember the types. Then comes the dislocating, where the head is completely dislocated away from the acetabulum. Then comes your Perthes type. Perthes type is again one of the type of tuberculosis. Then comes your protrusio acetabuli, atrophic. mortar and pestle. See, I would like to tell you some things so that you will easily remember. Okay, see, normal you can easily remember. There can be Perthes type and there can be atrophic type. These three you can easily remember. Normal, Perthes, atrophic. Now comes the remaining four types. So anything in the hip can be dislocation. You don't have to remember in the order. Type 1, 2, type 1 is normal, type 2 is acetabulum. No. These can be randomly remembered. But please remember it can be normal type, Perthes type, atrophic type. Then comes your dislocating type. So what are only now you have to remember these three special types wherein it is a traveling acetabulum type, protrusio acetabular and mortar and pestle. Okay, I'll show you the diagram, then you can remember. So there are roughly 7 types of radiological classification as per Shanmugasundaram's classification. Okay, I will come to that little later. Before this, okay, protrusio acetabulum. Protrusio acetabulum is the head goes into the acetabulum. By that you mean acetabulum is generally like this, but if it protrudes because of the softening, if the acetabulum becomes soft, you look at the diagram here, it has gone inside. Unlike any other, look at this, it is only till here. Look at this, it has gone inside the pelvis. Inside the pelvis means the softening of the acetabulum. Because of the softening of the acetabulum, the head is pushed inwards. So just to recollect once again, normal type, Perthes type, and comes your atrophic type. So remaining 3 types are problems with the acetabulum. So what are those? Traveling acetabulum, where the acetabulum is very, very wide. In fact, traveling acetabulum is a misnomer. It is a head which is traveling, which is wandering. This is called traveling acetabulum or a wandering acetabulum type. In fact, the head is wandering from inferior to superior aspect. Then comes your protrusio type, dislocating, and mortar and pestle. I'll show you the diagram in subsequent slides, then you'll remember forever. Okay, these 2 things you have to remember, Babcock's triangle and Watt's triangle. These are frequently associated with MCQs. That's why I have picked up. So Babcock's triangle here in an inferior part of the head in the epiphysis. This is the commonest site of onset of tuberculosis. Commonest site of onset of tuberculosis. Don't get into busy slides here. Just remember Babcock's triangle is commonest site of onset of tuberculosis. And just for the completion's sake, I have put this Watt's triangle. Watt's triangle is with respect to osteoporosis only, not related to tuberculosis. So this is the Watt's triangle. This is the Watt's triangle. So in osteoporosis, what happens? The triangle becomes wide and wide. It goes on increasing in the size because of the disappearing of the trabeculae. So when the trabeculae starts disappearing, this clear zone is widened. Widening of the Watt's triangle is seen in tuberculosis. Babcock's triangle is a small inferior triangle in a femoral epiphysis, which is a common site of tuberculosis origin in the hip. So for that, I have one more slide to show you. What are the different site of origin of tuberculosis in the hip joint? Okay, before this, see this mortar and pestle, you remember in village side or whatever, even in ICU nowadays, you see mortar and pestle. This is pestle and mortar, where in ICU nowadays we are using this for crushing the tablets and feeding it through the nasogastric tube or a rice tube. Just then, if you, in case you are posted in medicine or whatever, you get to see this. And of course, in village side, it is used to crush the hard nuts, mortar and pestle. Okay, see, look at the diagram of this picture, where this is like a wide cup and this is like a hammer hard tool to crush the nuts. This is a mortar and pestle type of tuberculosis. This of course is a one such schematic representation. Okay, a 30-year-old HIV patient is on ART, has pain in the hip. Remember, flexion, abduction, external rotation is there for 2 months. What is the likely diagnosis?
TB.
Hello?
Transient synovitis.
Transient synovitis. Manjunath. Anybody else? See, you would be correct if it was tubercular synovitis. Remember, transient synovitis is a self-limiting disease because of anything else which settles down within 3 weeks. It is a self-limiting disorder, I would say, or a disease, where with just rest and analgesics and traction, patient becomes all right. That time it is transient. But here, remember, it is Faber. Faber means it can be synovitis. Now, what are the choices you are having here? Septic. Look at this. It could be tuberculosis hip also. In a stage of early synovitis, you will have this attitude. So, he has given a duration of 2 months, means it is not transient. And then comes your HIV on ART. So the incidence of tuberculosis is high in HIV patients. Secondary tuberculosis incidence is very high. So the answer is
TB hip.
okay. Deformity of the hip joint in case of tubercular synovitis. Okay, it is a no-brainer. You have to just read carefully and tell me the answer.
Option A.
Yes,
First
very good. Okay. First radiological sign of acute tuberculosis. I have not covered this, but you should take a chance. I will come to that little later. First radiological or early radiological sign of tuberculosis.
Space reduction.
Anybody?
Reduction of joint space.
Reduction of the joint space. No. Anybody want to take one more chance? So it is answer is localized osteoporosis. Please remember, whenever I will talk currently only about the TB hip, then we'll come to the other joints. See, whenever there is a starting of the tuberculosis, especially in a synovium here or in a Babcock's triangle, there is intense inflammation. There is a severe inflammation. So severe inflammation, what happens? There is hyperemia. There is excessive blood flow, right? So because of the increased blood flow, there is high bone turnover and there is a regional osteoporosis. For two things, localized osteoporosis is two things because of the hyperemia and loss of calcium into the blood, and second is disuse osteoporosis. Because of the pain, the patient doesn't move his hip, and because of hyperemia, there is a loss of blood calcium. Okay, then comes your, okay, I'll draw the diagram once again. So there is intense hyperemia. Then comes your synovial hypertrophy at the edge, because the cartilage here is not covered by the synovium. Synovium is covered only in the capsule here on the neck, on both sides. Capsule is, you please remember, it is like a balloon, collapsed balloon. There it is lined by the synovium, which causes. So after synovitis sets in, there is synovial hypertrophy. Synovial effusion, of course, you have to remember what happens, change in biochemical changes in synovial effusion, which is helpful in diagnosis by FNAC. Fine needle aspiration is there is increased total lymphocyte count, decreased mucin. These two things are there as, and decreased glucose. This I am talking the changes, biochemical changes in the synovial fluid. Please remember this. So whenever you aspirate the joint and look for biochemical markers, you can look for biochemical changes or do gram staining or Zn staining or PCR. All this can be done for microbiological establishment of the diagnosis. These are the indirect markers or indirect biochemical parameters. Okay, I will not deviate. Please remember, I was here for a localized osteoporosis. Then what happens after some time? This, because of excessive synovial hypertrophy, pannus formation, there is erosion. The bone starts getting eroded. There is irregular bony erosion. Then comes your reduction in the joint space. After the joint space reduction, then comes the fibrous ankylosis. Okay, please remember, these I am talking of radiological sign. Initially, it is only hyperemia. Then comes the erosions, joint side erosions will be there. Then comes the joint space reduction. Once the joint space reduction is there is a trabeculae or fibrosis across the joint and it leads to ankylosis. So earliest sign here in radiograph I am talking. This is not MRI or anything else. Earliest sign on X-ray of tubercular arthritis is loss or localized osteoporosis. It can be hip, it can be knee, or it can be any joint for that matter. Most important thing you please remember in TB hip and osteoarthritis difference is, in osteoarthritis there will be sclerosis. In tubercular arthritis or rheumatoid arthritis there is osteoporosis. Okay, right. So this I have explained again. This is, I need not go once again here. Okay, this is one random picture what I have picked. This can be, I was telling, this can be traveling or wandering acetabulum, where the head wanders actually. The head wanders inferiorly, superiorly, anteriorly, and posteriorly, but it is called as wandering acetabulum, right? Girdle stone arthroplasty is carried out for, yes, come on. Anybody?
Hip infection.
Quick. Shirisha, your net is poor, I guess. Your audio is not good.
Yes, sir.
Okay.
Hip
So,
infection, sir, but chronic or acute, I don't know.
yes, it is chronic hip infection. I will explain you what is girdle stone arthroplasty in this radiogram. See, I have not talked about the treatment of tuberculosis of the hip, which I will talk in a subsequent slides. This one example I wanted to show, girdle stone arthroplasty, also called as excision hip arthroplasty. Okay, girdle stone, it is named by the one who has devised this, wherein you have removed the head and the neck part of the femoral head. This has been removed. This is how it looks. Nowadays, this is not being done. Girdle stone arthroplasty, the disadvantages is hip becomes unstable. But in Indian scenario, where the patient wants mobility, here the patient gets a painless hip he gets, but at the cost of stability. He will get mobility is more, but stability is lost. In girdle stone arthroplasty, they can twist the question and ask you again. Girdle stone hip arthroplasty gives mobility but takes away stability. So when we are asking for more, we want mobility and stability. What is the treatment which offers stability more than mobility? Is in arthrodesis. We will fuse the joint. Surgically, we will do the fusion. If it happens by nature, it is ankylosis. If it is done by surgery, it is arthrodesis. So in arthrodesis, you will get painless hip, stable hip, but mobility is taken away. There, stability is given importance, means it is arthrodesis. Mobility is more than stability. Here it is girdle stone arthroplasty. Girdle stone arthroplasty is you remove the head and neck. But now we want both mobility and stability. So what is the procedure? What we are doing now is total hip replacement or total hip arthroplasty, where girdle stone also gives painless hip, arthrodesis also gives painless hip. But girdle stone gives mobility, arthrodesis gives stability. I want both for my patient. He has to have painless, mobile, and stable hip. So, what is the answer? Total hip arthroplasty is the answer. All these three options of arthrodesis, girdle stone arthroplasty, and total hip replacement are a salvage operation. They are a salvage operation where the joint is destroyed beyond repair. These are in the stage of advanced arthritis or stage of dislocation or stage of sequelae. Okay, remember these three procedures, right? Okay. Okay, if I left anything else in the hip, I will come to that. But before this, closing the hip and going to the knee, please remember, how do you treat tuberculosis of the hip? In the synovitis stage, in early arthritis stage, the treatment is different. Advanced arthritis, stage of subluxation or dislocation, stage of sequelae. Okay, these three things I have told. the total hip replacement, arthrodesis, or excision arthroplasty. In synovitis and early arthritis, our goal should be restore normal hip, where we will not remove the original bones. Native bones are restored, native joint is restored. And how do you do that? You start ATT. Of course, you know the regime, which I will not go into that. Right is rifampicin, INH, pyrazinamide, and ethambutol. So then, of course, the regime you will know better. But in osteo or skeletal tuberculosis, we use up to 9 months. In spine, sometimes we use up to 18 months duration. So ATT is one part of the treatment. So what we call as chemotherapy or ATT. So this is treatment, medical line treatment. What is a supportive treatment? You have to give rest to the part. How do you get rest to the part? In upper limbs, you put immobilization or slab. You immobilize the part. Why do you immobilize the part? By mobilizing it will be painful. By immobilization you give rest and make it pain free. In lower limb, what they do? They give traction. In upper limb, they do immobilization. So first is ATT, second is rest, third is immobilization by a splint or by traction. Okay, then you of course watch for the response, clinical response, hematological response, and radiological response. Then what happens? If it is responding, you continue the treatment. You are not intervening. If it is not responding, then comes your surgical intervention under the cover of ATT. So what you do? Surgical options are plenty. I am talking of only in synovitis and early arthritis. So what you do in synovitis? You do synovectomy. You do joint debridement. So you restore the original bone here. You don't do excision, you don't do resection. So synovectomy, joint debridement helps in ATT, the drugs to reach the joint. Okay, we'll go to the knee. Of course, you should remember in osteoarticular tuberculosis, most common is spine, then comes your hip, then comes your knee in this order. Okay, suppose there can be a question wherein most common site of involvement of osteoarticular tuberculosis is definitely spine in this order: spine, decreasing order, spine, hip, and knee. Spine, I had told you in the last class, it is dorsal-lumbar junction. Okay, we'll not go into that. So tuberculosis of the knee, there are very few things what you should remember. It's a simple topic. Triple deformity is a late presentation of tuberculosis knee. There's 3-4 slide only regarding the triple deformity. So what is triple deformity? Flexion, external rotation, posterior subluxation. And triple deformity is not specific for tuberculosis. It can happen in polio. Okay, I will show you some diagrams. See, look at this. Posterior subluxation. This tibia is subluxated posteriorly. You look at this. Tibia is subluxated posteriorly. Why it happens is, you remember, I will go to this slide. There is, why this happens even tuberculosis, this IT band you should know, maybe somebody will cover in the anatomy class. In polio, almost all the muscle gets paralyzed. But IT band is predominantly fibrous. It doesn't get paralyzed. It is only a small muscular tissue with a long fibrous band. So it attaches on the lateral aspect of the upper end of tibia. So in tuberculosis, what happens? Quadriceps becomes completely wasted because of the painful knee, no mobilization of the knee, hence disuse atrophy of the quadriceps and all the thigh muscles. Okay, so the IT band is the only thing which is going there and it gets contracted. So what it does, remember it is attached to the anterior part of upper end of tibia. So it pulls laterally, it pulls posteriorly, and it pulls externally. So it causes flexion, posterior subluxation of the tibia, and external rotation of the tibia or the leg, and in fact it is valgus deformity. In fact, if you are intelligent, you have to please remember it is quadruple deformity. The general practice is triple deformity, but please remember flexion, external rotation, posterior translation of the tibia, and valgus of the knee. Okay, if it is only these three, it is triple deformity. Don't get confused. You remember IT band, then you can easily remember all the actions of the IT band. Yeah, so this is what I was talking, triple deformity. So look at this posterior subluxation of the tibia, completely damaged joint, flexion external. Okay, so one small mnemonic is there for it. Okay, look at this, triple. T for tuberculosis, rheumatoid arthritis, IT band contracture, polio, lower clotting power or hemophilia. Just to these, of course, look, both are similar. Instead of remembering hemophilia, they have expanded that. Tuberculosis, rheumatoid arthritis, IT band contracture, polio, lower clotting power or excessive bleeding. That is hemophilia. Okay, so we'll come to some MCQs. Treatment of triple deformity. What is the treatment? Come on, very easy. Triple deformity of the knee secondary to tuberculosis. Yes.
ATT plus
Attempt. ATT
fourth plus
plus
replacement.
very good. ATT plus replacement, because treatment triple deformity is already advanced arthritis. No point in immobilizing. Just by immobilizing, it will go for ankylosis. We don't want that. To immobilization and debridement, by doing debridement, if you are expecting to get some range of movements, then this is good option. But triple deformity means the entire joint is disorganized. All the ligaments have been destroyed. So only option left is ATT plus replacement. Triple deformity, true statements are, yes, good question. Come. TB knee, yes or no?
Yes, sir.
Simple answer. Very good. Posterior subluxation of tibia, external rotation of the leg, flexion of the knee. Correct? Is it correct?
Yes, sir.
Very good.
Yes, sir.
Posterior subluxation of the femur, external rotation of the leg and flexion of the knee. Is it correct?
No.
Definitely no.
No.
No. Because this is correct. Posterior subluxation of tibia, external rotation of the leg, extension of the knee. Is it correct?
No,
No,
sir.
sir. Flexion.
No.
Very good, very good. So IT or iliotibial tract or IT band is important for the mechanism, right or wrong?
Yes, sir.
Yes,
True.
sir.
Very, very good,
Right.
Mandela. Yes. Most common cause of monoarthritis in children. You should answer this. See, even if, just because we are dealing with tuberculosis, you should not answer. Osteoarthritis is in old age. Rheumatoid arthritis in adolescent, or there can be, of course, JRA, but it is multiple joint involvement. Okay,
Septic earth.
septic arthritis or tuberculosis. These two options are there now. The answer is tuberculosis. You should know. Most common cause of monoarthritis in children, okay, is tuberculosis. Please remember that. Complication of joint tuberculosis. Yes, I was talking all this while. What is the complication, or what is the sequelae, or what is the outcome?
Fibrous ankylosis.
Very good.
Oncologist.
Yes. So you please remember, in fact, I did stress in the last class as well, the outcome of treated or untreated and advanced tuberculosis is fibrous ankylosis, except in spine, where it causes bony ankylosis. Okay, so whatever way you please remember, tuberculosis joints fibrous, tuberculosis spine bony. Okay, when it comes to bony ankylosis, it is a sequel of septic arthritis. Please remember this. Don't get confused at all. The complication of joint tuberculosis is fibrous ankylosis. Some important thing about fibrous ankylosis is it is painful. Some movements are present. But in bony ankylosis, it is painless because absolutely no movements are there. Just for completion, I am explaining here. Okay. Which of the following is a feature of triple deformity? You can answer this question.
Posterior subluxation.
Yes, posterior subluxation. Nothing much. Okay. Just few slides on tubercular shoulder, elbow, and hand. No much questions have been asked in the past, but you should, maybe in future they can ask. Tuberculosis of shoulder is very less common. Remember this, less common. Starts as osteitis. One thing you please remember, any tuberculosis for that matter, it can start in synovium or it can start in the epiphysis or bone. If it is in the bone, it can cause tubercular osteomyelitis. If it is in the joint, it is called as arthritis, isn't it? Arthritis in the joint, osteomyelitis in the bone, tubercular osteomyelitis or tubercular osteoarthritis. One more important thing, I think I have that in slide. Tuberculosis of shoulder most commonly presents as caries sicca. You know what is meaning of sicca? Dry. Sicca syndrome. You have heard of sicca syndrome in pathology?
Yes, sir.
I will explain that what you mean by Keri-Sika. Caries you know very well. Caries you know DK. Okay. So the one more slide is there. Yeah. You please remember this is a very important slide. Don't go into everything here. Whenever there is tuberculosis in the body, tubercular arthritis, it can be two types. Proliferative or exudative. Okay, exudative means there is lot of pus formation. Proliferative means there is lot of fibrosis. Okay, so Keri-Sika means it is proliferative type. Proliferative type. Here it is most commonly Keri-Sika is seen in shoulder. In all other joints, most commonly it is Keri's exudata. Don't bother about this, that is not for your level. But please remember it is proliferative type or exudative type. Okay, what I was mentioning, for that you should know if the synovium is affected in the beginning. So synovial inflammation happens, and because of inflammation there is lot of synovial fluid secretion. This is exudative type. But if it happens in the bone, it leads to intense fibrosis. Hence, it leads to proliferative type of tuberculosis. One typical thing about shoulder tuberculosis is it starts in the bone. Unlike in the knee, in the hip, in the wrist, it starts in synovium. That's why Keri-Sika is more common in TB shoulder. Of course, there are certain things which I will highlight. See, swelling of course will not be there because there is no effusion. Wasting will be there in any type of tuberculosis. Cold abscess of course cannot be there. There is no secretion. Sinus formation is definitely not there because there is no pus formation and which is not let out. Movements are absent in all the type of tuberculosis. One more important thing before I forget, I will explain you. See, whenever you are talking of osteoarticular tuberculosis or skeletal tuberculosis, you should remember the process or pathology can start in synovium or it can start in the bone, which leads to osteomyelitis, synovial leads to arthritis. It can start in tendon synovium, synovium covering the tendon. It can start in the bursa. These are all the sites wherein you can get tuberculosis. Okay. So just like there is a typicality in tuberculosis shoulder, as I said, wherein it forms a Keri-Sika. Keri-Sika is dental caries or decay is in tubercular shoulder. So specialty of tuberculosis of the wrist is you get to see compound palmar ganglion. Compound palmar ganglion, wherein you remember, if you can remember in the anatomy class you have been explained, there is a carpal tunnel here. There is a flexor tendon sheath covering all the flexors. Okay, it covers both flexor tendon superficialis and flexor tendon profundus, flexor digitorum profundus. So if there is tuberculosis in this synovium, it becomes swollen. This is again, I told you, exudative type, where there is collection of the caries or pus. and it becomes a fluctuant swelling going into the palm. But there is a constriction band here because of the carpal tunnel. This fluctuant swelling, which extends from the palm into the forearm. Fluctuant swelling extends from the palm into the forearm. Here you can see fluctuant swelling. If you press here, you get the pulsatile sign on the across the carpal tunnel. So this is compound palmar ganglion, very typical of tuberculosis in the wrist. Yeah, this is one diagram I wanted to show. Look at this. Here you can easily see the swelling. Here there is carpal tunnel. Please don't mistake. Carpal tunnel is situated here. It is not situated here. Many people get confused. It is in the part of the palm, carpal bones. This is your carpal tunnel. So there is a swelling in the thenar or hypothenar region, which is fluctuant. Hence, it is compound palmar ganglion. I think with that, I come to the end of the class. There's one more, one more slide I wanted to show. In tuberculosis of the joint, as I said again, specific thing you remember, spina ventosa. Okay, ventosa is a cavity. It is an Italian word. Spina is actually, what is spina is, spine, how the word is derived is arrangement of sequence of bones like this. Okay, but please remember here, spina ventosa means tubercular dactylitis. Spina they also called as short long bones, but please remember tubercular dactylitis, dactyl, polydactyly, digits. So tubercular dactylitis, spina ventosa. There is a ballooning of this metacarpal, or there can be ballooning of the inward phalanges. Any short long bones affected by tuberculosis or tubercular dactylitis. Dactylitis is what? Inflammation of the digits. Tubercular inflammation of the digits. If there is a ballooning or swelling of the ballooning out, don't confuse yourself for the swelling. Here you please specifically remember this is ballooned out. Look at the other metacarpal, they are normal. So ballooning out of the short long bones in the hand is called as tubercular dactylitis, also called as spina ventosa. Okay. TB hand, there's one question relevant to this, is here spina ventosa, Kerisika in tuberculous shoulder, Pott's disease in tubercular spine. Okay. Yeah, with that I come to the end of the class. Okay, who all are still there? All are still there?
Yes, sir. Thank you, sir.
Yes, sir.
Pulkesh, you
Yes,
can
sir.
stop recording.
Yes, sir. Thank you so much, sir. Thank you all.
Thank you. I'll close the meeting if there are no questions or anything to be discussed.